And the unenviable task of summing all this up, what's going on in the U.S., is going to go to Kelly Scanlon from the CDC. We are used to Larry Grumenstrom having this role. He's now at the World Health Organization, but Kelly has very kindly agreed to come in and help us. She has worked for many years on these issues, and we're happy to have her, so please welcome her.
I've heard it's the white. And I will, first of all, thank you for having me. It's an honor to be here. Yeah, absolutely. And I will try to keep my... Oh, is too high. We know why that is. And I'll try to make this briefer than I planned. Now, the advancing is... The right, okay. So providing support for breastfeeding is a key priority to CDC's Division of Nutrition, Physical Activity, and Obesity. And I'm going to update you on our key strategies in the U.S. and some of the progress we're seeing as a result of the collective efforts across the country. The health benefits of breastfeeding are well documented and, of course, very familiar to this audience. Not breastfeeding increases the odds that infants, children, and mothers will experience the acute and chronic conditions shown here. This is the evidence base for higher income countries. It's been very important for us to have this evidence base for higher income countries. It's helped us politically in making the case for breastfeeding, and hopefully it will be updated soon. Recognizing these nutritional and immunological benefits, you're also all aware of the recommendations of the American Academy of Pediatrics and other organizations for exclusive breastfeeding for the first 6 months, followed by continued breastfeeding for at least a year and at least 2 years globally. And these are the indicators we track at CDC, and we are seeing continued progress in the United States on increasing rates of breastfeeding initiation, duration, and exclusivity. These are the Healthy People 2020 goals that we track. The day that I left to come here, the 2014 National Immunization Survey data arrived, and so we've started that analysis, so we'll be able to add 2012 births to this graph shortly. But it's not all good news. We have these increasing rates, but we know it's not all good news. We continue to see disparities in breastfeeding rates. We see much lower breastfeeding rates among the infants from the poorest families, from infants living in rural areas, African American infants, younger infants. One of the largest disparities we see, and that we have focused on the most at CDC in recent years, is the disparities we see by race. So while 80% of white infants start breastfeeding, only about 60% of African American infants start breastfeeding. And because our 6 and 12-month rates that we report are also among all U.S. infants, not among the initiators, among all U.S. infants, we continue to see those much lower rates at 6 and 12 months. And that then results in fewer African American infants receiving those health benefits of breastfeeding that I just highlighted. I've been looking at the data. I love data. And so I've been looking at the data many different ways. That if you look at, and please don't tweet this because some of this hasn't been released yet, if you look at among the initiators, you will see that the disparities are not as great. And so, which is making us think more about the importance of that support so early, and so happy to hear about the support in OBGYN practices, that to really try to help with that intention and that early support in the hospital. In fact, so we're going to try to release that information soon. The other not so good news is we continue, of course, to see that decline in breastfeeding, especially exclusive breastfeeding once breastfeeding starts. So I don't know if I have a pointer, but 80% of U.S. infants start breastfeeding in the United States. They start exclusively breastfeeding. By about 7 days, that is down to 60% of infants in the U.S. exclusively breastfeeding. It's reduced to 19% by 6 months. And so any breastfeeding does sustain longer, but it also drops to about 50% of infants by 6 months. We know that drop-off in breastfeeding is not always because mothers want to stop breastfeeding. In a separate study, we found that 60% of mothers reported that they did not breastfeed as long as they wanted to. So therefore, a major focus of our work at CDC is supporting breastfeeding mothers. And we do this through three main strategies that we have focused on in recent years: improving hospital support for breastfeeding, improving support for employed women, and improving access to support in communities. And then we're able to emphasize equity by targeting our resources to those hospitals and communities that are serving populations with the lowest breastfeeding rates. And we've specifically targeted populations serving more low-income women, as well as populations serving more African American women. And so I'm going to just go through a little bit of those main strategies and some of the activities under those. So in terms of our main activities under hospital support, that includes, one is the administration of the MPINC survey that I mentioned a few times and others did. That is administered to all birthing facilities in the United States. And so it is actually a census. We have a response rate of about 83%. It's a biennial census. And because it is a census, it provides that unique opportunity that we can return to each participating facility, about 2,800 facilities, a customized benchmark report that shows all the practices that that facility reported on, how they score in terms of those quality scores, how they compare to other facilities in their state, across the country, other facilities of similar birth size. And so that, in that way, MPINC, although it serves as one of our surveillance systems, it also serves as an intervention, and I'll be showing some of the results. We have also, another main activity is we've been, with some of the additional money that we received through the Prevention Fund, which has been great, we've been able to fund the assisting individual hospitals to achieve baby-friendly designation. One of these projects, Best Fed Beginnings, was a 3-year collaborative agreement with the National Institute of Children's Health Quality. That just concluded on March 31st. And then a new project, Empower Breastfeeding, is currently underway, and I'm going to provide a few more details on those too as well. One of our main activities to improve support for employed women includes funding states to implement practices to ensure compliance to the federal lactation accommodation law that we heard a little bit more about yesterday. Currently, about 19 states have selected this activity in their funding, and that's actually going beyond the law. So the law is covering non-exempt workers, so it's not covering a lot of workers out there. It does target the probably the lower income women by in terms of, but it's in terms of the personnel policy. I'm not an expert on it, but how it came out. But there's also been a lot of confusion. It does cover employers that are serving under 50, but they can apply for to be excluded, but it's not automatic. And so, but there's, I think sometimes employers of what small groups believe that they're not covered by that. But this is actually trying to go, a lot of states are using this money to try to go beyond and cover everyone, cover those of us. For example, we're not covered at CDC because we're salaried workers. So, one of our other main activities has been building the evidence base for maternity leave and increased breastfeeding. And so we've been trying to publish those studies specifically that look at time spent after the baby's born at home with the baby, and helping women meet their own personal intentions for breastfeeding, because some of the questions we were getting back was about the evidence base. Some of those main activities under improving community support have been to improve access to lactation support in the community. Really, this is what we heard repeatedly in the work when we bringing in experts to help us reduce racial disparities in breastfeeding is really getting money out to community-based organizations. I mentioned that a little bit. We focused on lactation support in our annual breastfeeding report card last year. We've been able to use some of the funds we received from the Prevention Fund to fund NACHO, to then fund community-based organizations. And I'm so glad to hear some of the stories, like in Virginia, of what's being done, and we will be collecting those stories because we want to continue to highlight those stories from around the country, because I think that'll help us make the case to continue to have this support. So This is a map of where we have CDC-funded state and community activities. And we are very excited to say for that the first time CDC was able to offer breastfeeding funds to all 50 states and Washington, D.C. through two separate funding. One has a long name, State Public Health Actions to Prevent and Control Diabetes, Heart Disease, Obesity, and Associated Risk Factors and Promote School Health, or we call it 1305. But because breastfeeding was only included in the enhanced grants, only 32 states were able to work on breastfeeding, so when we got that extra money from the prevention fund, we were able to fund ASTO to put out the money to the other 18 states in Washington, D.C. And so in those states, they are working on those three strategies. They are choosing the strategies and then the activities under those strategies that make the most sense for those states. And then the stars are where the NACCHO awards are. And so, so right now, just for your interest, 36 states chose to work on maternity care practice, 19 on worksite, 12 on improving access to peer and professional support. All of the NACCHO grants in the START are about increasing access to peer and professional support in the community. So I just want to end by sharing with you some of the progress that we are seeing on hospital support for breastfeeding. We have monitored hospital support through MPINC since 2007. And if we look at the data in this graphic across the 4 biennial MPINC surveys, we see that the overall MPINC score has increased from 63 out of 100 total points to 75 points. And we are seeing that improvement across those domains of care that we report on: labor and delivery, feeding of breastfed infants, breastfeeding assistance, mother-infant contact, which is what we highlighted in 2013 in the report card, keeping mothers and babies together, especially during that hospital and hopefully at some point more time postpartum. Discharge care, staff training, structural and organizational. As I mentioned, we believe MPINC is working as an intervention in those hospitals. Hospitals are eager to, we've seen the change over the years of the survey. We're getting lots of messages through the MPINC mailbox. Hospitals are looking for the survey, wanting to fill out the survey, working on the practices, and so it's been a great project. We also just a few weeks ago, published the results even on one specific practice that I'll highlight, the distribution of formula gift bags to breastfeeding mothers. The percent of hospitals that are providing discharge packs with formula to breastfeeding moms has decreased from 73% back in 2007 to about 31% in 2013. So we are concerned about where gift bags may be going, and so start thinking more about the we don't want them being released from the OBGYN or other practitioner packages. Yeah, so we realize that this is not capturing that, but still, there's always more work to do. And all the other MPINC data, it's all on our website. And we're continuing to see, of course, those improvements in maternity care practices across the United States. So this slide shows the improvements in state MPINC score. That's just the average of all the hospitals participating in the state from 2007 to 2013. Again, this is all on our website, but not in this format. You'd have to go into all the state tables. So just an example, in 2007, 15 states received a score of less than 60 out of 100, and only 2 states a score of 80 or more out of 100. In 2013, only 1 state was at the low under 60, and 13 states are 80 or more. But I will tell you that one state, we have some other great news coming out, because when you look at the individual practices, so ideal practice on those 10 steps, it's also on the website, but we're going to highlight it in another release. There's been great improvement in Mississippi on the number of the 10 steps with ideal practice. So, and so occasionally I'm going to ask to please not tweet that, because those are all new pieces coming out. Thanks. Most of it's all released. I meant to say something about that in the beginning. So on October 6th, we are going to release a CDC Vital Signs on maternity care practice. We're going to be using the MPINC data, highlighting state improvements in maternity care, as well as national. And for that reason, there's not going to be a lot of news coming out in the months before, because we've been asked by the CDC Vital Signs team to really not release a lot of other breastfeeding news, and especially on maternity care, but also on breastfeeding leading up to that. So I'm going to just share a little bit. I'm going to end with a little bit of the success also from the Best Fed Beginnings, the 3-year collaboratives that just ended. And this really hasn't been released, and I want the NICHQ to be able to release this. And so I'm only going to highlight very high level. But as you know, that this was that project. It was 89 facilities participated in from across the country. We were able to give priority of funding to hospitals serving populations with the lowest rates of breastfeeding. So by the end of the 3-year project, on March 31st, all 89 hospitals had progressed to the final phase of 4D pathway towards baby-friendly designation. 75 project hospitals increased their exclusive breastfeeding rates. 69 of those 89 project hospitals were designated or have completed and are just either have been designated and they're waiting for the results, or they, or the visits have been scheduled, or they're waiting for their visit, or they're waiting for the results. But 69. There are 200,000 babies are born annually in those 69 hospitals. So as a result of the project, 200,000 more infants and mothers will receive optimal breastfeeding support and care annually. So the importance of changing policy and environment, and then having long-term improvements. And so that project ended, and I will say that the increase in designations with Best Fed Beginnings and all the other efforts, the IHS efforts, all the efforts across the country, have really accelerated designations across the country. So whereas back in 2007, less than 2% of babies were born at baby-friendly hospitals, we are at about 13% today. It's going up. Like every week we hear of another designation. I actually want to get a bell for the team that we ring every time we get the phone call from Baby Friendly USA. So it's very exciting that it's continuing to increase, and that this is optimal support. And we keep making this point for both breastfeeding and non-breastfeeding infants. All infants being born are benefiting from the baby-friendly practices that are in place. And so we're now funding a new initiative to continue to increase the number of baby-friendly hospitals. And this is actually through a contract through APT and they are working with Carolina Breastfeeding Institute and others to work with up to 100 hospitals that will receive training and technical assistance to implement the 10 steps and move towards baby-friendly. And we also want to, within this, help to identify some of the best practices, because this is a little different model moving towards baby-friendly. It's more direct assistance to the hospitals. So thank you. We look forward to continued progress in supporting breastfeeding. Thank you for all you do at the Academy. Thanks.
May I ask a question? May I ask a question?
Sure. Sure.
As far as your state funding.
State funding.
State funding.
Funding that goes to the state health department.
Right. Do you require that the state or states focus the money, target the money on WIC populations, or just the general community?
No, it's the general community.
Sorry, can you answer the question at the microphone?
Oh, I'm sorry. It is I'm trying to think of the details. One of the requirements was choosing from the 3 strategies that I talked about, but not in terms of there are some states working with WIC communities.
Well, see, the problem I have is this.
Mm-hmm.
My state, I can only speak about my state.
Mm-hmm.
When the state does receive money, it never discloses to the community that this money is available. If there are any type of technical assistance opportunities for breastfeeding professionals, we don't know about it. I wouldn't know any of that information that you just disclosed, and I know Mississippi's involved somewhere, if you had not just disclosed it, because the state receives money, the state has a close network of friends, you know what I mean, and they give contracts to their friends and their allies and their whatever, nepotism. And a lot of times the general community has no idea that monies have been received and that you all are attempting to do this work within our state. I would like for you all to require the states to disclose that this money is coming and what you intend for the state to do with it.
Well, CDC, so our program branch that works with the state health department, and they are the project officers on the project. They know the population and the details of all the projects, but there's not state health departments apply, and we look at the details of the project. There's a whole review process, but yeah, I don't think we know how states are then, I mean, we can't interfere with who they're contracting with in the state. I mean, one of the reasons we went with the NACCHO grant as well was to have an opportunity to work with an organization that would distribute directly to community-based organizations, even though there are many states who are doing that from the state health department. But I'm going to take that information back to the program.
It doesn't have to go through the Federal Register? It doesn't have to be announced?
The funding opportunities are all announced. Oh, I thought you meant from the state. I don't know about from the state health department who they subcontract with, but all of our funding is all publicly announced. It's on CDC websites. It's on.
Well, yes, I know about that. I meant from the point that the state receives the
But
money.
you're wondering, once the state receives it, we're not involved with who they give it to within the state.
Well, they also fail to disclose that they have received the federal dollars and what they intend to do. And when I have called my State Department of Health before, once learning that they have money, okay, what's the plan? And then how can the community be involved in the plan? I think the community should have some input into what the state intends to do to serve the community. Well, we don't get that opportunity, and I just get really sick and tired of seeing federal dollars come to my state, and we don't know about it until after the fact, and we don't see any outcomes on the ground. But money continues to come, and that's not just your agency, it's every federal agency, and the conditions remain the same.
Thank you.
Thank you.